of 8. And there is a tendency for those that are not salaried to have a lower number, which is kind of expected. But you can see that I think we can do a lot better in general, especially for the salary. We should be able to see quite a few more children. Now, if you look at the total iCCM treatments per child per year, the point here is that it doesn't make a difference whether they're salaried or they're volunteer. You can have programs that are giving out a lot of treatment regardless of whether they're salaried or not. And the no is a lighter color, and the yes is the darker color. Okay, so what we're doing here is looking at the percent of expected total iCCM cases here, and we're looking at the ratio of active CHWs per 1,000 under 5. And we're splitting, showing you whether it's salary or whether it's volunteer, which is the lighter color. And there is a tendency, you see, to have a ratio of active CHWs a little lower in the salary, because they're supposed to support children. It's expected from them from the salary. But you can see that it's scattered all over here, regardless of whether they pay a community health worker or don't pay. And so for those that are salaried in here, we really want them to move up here. We want them to really increase the percent of total iCCM cases of expected cases that they're treating. And for the ones that are unsalaried, we'd also like them to move up. But they're going to move up in different ways. Obviously, you can increase utilization for the salary by increasing the number of community health workers per CHW. And to increase the utilization for the volunteer, you have to increase the number of volunteers that you have, because you cannot expect them to do the same number of treatments as the salaries of full-time salary workers. So here are some factors that we found when we compared two treatment rates. If you charge a fee, your treatment rate was low. Charging a fee is not a good idea. You are trying to reach the hard-to-reach, the poorest communities. You cannot charge these people to receive services. Paid CHWs and volunteers can both be affected, again, showing you the total number of treatments per year. There is a little tendency to be a little higher in the pay, but that's not 24.5, that's not a large difference. This is a program lead time to reach scale. This is very, very important. If you started to do an evaluation of your program, when you have not reached scale, and scale means whatever your intention was, how many community health workers you were going to train, and what area you were going to cover, if you didn't get to your goal and then you did your evaluation, or you looked at the data, it was just too low. You need some time, at least a year or more, before you can even expect to be having a higher utilization. You need to have an effective supply chain, and I think that's kind of obvious, but this is looking at programs with fewer stockouts and higher treatment rates. So this is looking at no stockouts. So if they had no stockouts, it would say yes. It's like a double negative. But no stockouts. And these had stockouts, and they have a lower treatment. You need to have effective supervision as well. So if we look at this, and these are the median percentage of received supervision in the last month. Those who were supervised had much higher iCCM treatment rates per child per year than those who had not received that supervision in the last month. And then an interesting thing looking at use of RDT. As expected, if you use the RDT and looking at malaria cases per child per year, if you use an RDT, you have a lower rate of treatment, which is expected because you better treatment. You're not treating everybody with a fever. You're just treating those who are testing positive for malaria. But a similar thing happens with pneumonia, and we're not 100% sure, but part of that could be that you're not having to dual treatment now. And people who really have pneumonia are being treated with pneumonia, and those who really have malaria are being treated with malaria, and that might be part of the reason that we're seeing that. But we're not 100% sure. Treating 3 illnesses does not negatively affect utilization for a specific illness. So here we're looking at malaria treatments per child per year, and whether the program is treating 2 or 3 illnesses. And treating 3 illnesses actually resulted in a higher malaria treatment rate. Similarly with pneumonia, 2 illnesses were treating 3 illnesses still resulted in a high pneumonia treatment rate. So then we wanted to go and say, okay, this data we've been showing you is based on routine reporting or a CHW survey. So how does that relate to coverage from household surveys? How does that relate to the way that we normally do the session? So we look at coverage data, and that is from a household survey. It's usually conducted at baseline and then at endline of the evaluation period, and it's usually administered to caretakers if children are 5. But what we do when we do this is we go and we ask the caretaker to recall in the past 2 weeks if the child has been ill and has got treatment, and actually what kind of treatment that they have to report, which is kind of difficult to do in survey. So the percentage of all children with an illness whose caregiver reported the child received appropriate treatment is the definition. And for malaria, if the child has fever, received ACT. For diarrhea, if the child has diarrhea, received ORS and zinc. For pneumonia, if the child has cough, fast breathing, due to problem tests, received antibiotics. Just know that pneumonia self-report is not the greatest measurement in the world, but it's what we have. So if you look here at the percent of children under 5 with fever who received an ACT from those studies that we had coverage data on, you can see that there was an increase in almost all of them. There was a few that did, but almost all of them had an increase from baseline to endline, with some very dramatic increases that you can see there. And then if you look at the source of treatment, pre and post, for those that we actually had the information on source of treatment, which is not always collected in these surveys, you can see that the proportion that were treated by CHW definitely increased from baseline to endline. However, our question is, did our treatment data relate to the coverage data? And unfortunately, that was possible. We could not find that. There was a strong association. You should fall on that line and just shut up. And you can see Mozambique and Southern Sudan fell on that line. But the other ones were all over the place. And you had a group that had lower coverage but higher percent of expected. That was 5 out of 12. And then you had a group that had higher coverage but a lower percentage of expected from what they're reporting data. So you had to go both ways. Well, look at this, Well, also when we look at diarrhea, we had a similar issue. 3 out of 9 had a strong association between routine and coverage. In pneumonia, it was 3 out of 11. So, what does that mean? It's not a good recording. We have 2 data sources, and we don't know exactly the quality of both of those data sources. We try to make the quality, but first of all, on the routine reporting side, is there under-reporting? Is something that we haven't been able to adjust for? Or inaccurate reporting that might be accounted for this? On the household measurement side, we're only asking about the last 2 weeks, and we're relying on self-report. So there could be problems on both sides. But the point is, despite this, coverage data shows that CHW have contributed to increased coverage of patients with pneumonia, malaria, and diarrhea. So overall, there's a few limitations, a small number of studies. We had to use some regional estimates. We had had to make these adjustments for fast reading. And definitions of certain variables were not standard. We tried to standardize that, but in some cases there was quarterly supervision. In other cases, stockouts were measured differently in the past 3 months or in the past week. But we tried our best to standardize that. We really need to work better on having standard measures. We didn't present any demand side data, and this is really important because the issues we're fighting here is that there are not enough utilizations, not high enough utilizations, not high enough number treated for expected cases, and we really need to look at the demand side. You shouldn't expect something different from integrated communication management than you expect from a health facility in regards to demand. You really have to look at those issues. The geographic distribution of CHWs in relation to each other, the health facility, and private population, we didn't know that information, and we didn't know how long, with the CHWs, were they available. 5 hours, 8 hours a day, 7 days a week, we didn't have all that information. And the key findings is that the percent of expected cases treated, it was a consistent group of programs with high rates, much lower for diarrhea, in the middle for malaria, and higher probably than expected for pneumonia, which might indicate overtreatment. Treatments per CHW per month, there was a high variation reflected in the 2 main types of programs. Again, the 2 main types are programs with salary, CHWs which have a lower CHW to population ratio, tend to be government run. The programs with volunteer CHWs, a higher CHW to population ratio, they tend to be heavily supported by NGOs. And each type has a trade-off. Salary programs really must maintain or increase the caseload for CHW to improve coverage. And in some circumstances, they might actually have to increase the number of CHWs. In programs with volunteers, by default, you have to have a lower caseload. This is a part-time volunteer. You're not going to expect them to have a caseload by the salary. And you must balance the benefit of risk of asking for more treatments for each CHW or increasing the number of CHWs with the cost estimate national risk. User fees are a barrier. Paid CHW and volunteer CHW can both be effective, but deployment supporting content matter. Programs with time to reach scale, they have to have effective supply chain systems, effective supervision systems, should use rapid diagnostic tests, as is the recommendation for area in general. And in areas where iCCM programs were implemented, iCCM contributed to the overall increase in treatment coverage. And what are our recommendations? Increase utilization as a big recommendation. Do not charge fees, avoid adequate number of CHWs for the population targeted, maintain a continuous supply, ensure all CHWs are supervised regularly, integrate use of RGT, address lead notices where relevant, and this can best be done by integrating iCCM to the Board of Health Government Health Systems. And for emanating, examine local non-financial demand barriers and address them. We have to standardize routine iCCM monitoring and integrate with health management information systems. We need to regularly review and make better use of routine iCCM monitoring data. We have to plan and conduct a robust prospective evaluation and only evaluate programs after they have sufficient time to operate at scale. These